Welcome to Total Knee Arthroplasty Evidence-Based Update. This is an advanced continuing education course built for physical therapists, occupational therapists, nurses, and allied health professionals working in orthopedics and geriatrics. I'm glad you're here because the landscape of TKA care has changed dramatically, and what you learn in this course will reshape how you think about these patients. Here's the reality we're all facing. Over 1 million total knee arthroplasties are projected annually in the United States by the end of this decade. And our patient population? It's getting younger and more active. That means the expectations walking through our clinic doors are higher than ever, and the evidence we need to meet those expectations has evolved just as fast. The past several years have brought transformative changes across the entire TKA care continuum, from preoperative optimization and surgical technique to rehabilitation methodology and return to activity planning, fundamentally reshaping how our interdisciplinary teams approach patient care. What's driving this? An unprecedented volume of high-quality research. We're talking landmark randomized controlled trials, multi-center prospective cohort studies, and comprehensive systematic reviews that have genuinely challenged long-held assumptions about how we manage these patients before, during, and after surgery. Enhanced recovery after surgery protocols, ERAS protocols, are now endorsed as the gold standard by the European Society of Sports Traumatology, Knee Surgery, and Arthroscopy, and they've moved well beyond theoretical frameworks into measurable clinical implementation. We're seeing clear dose-response relationships between how closely a team follows the protocol and how well the patient does. The ERAS approach fundamentally reframes the surgical episode as a continuum requiring coordinated optimization across preoperative, intraoperative, and postoperative phases, rather than treating each phase as its own silo. At the same time, surgical advances including robotic-assisted arthroplasty, evolving fixation methods, and alternative alignment strategies have introduced new considerations that every rehabilitation professional needs to understand, because the surgical context directly shapes the recovery trajectory you'll be managing. And the evidence for rehabilitation setting selection has matured substantially. High-quality randomized trials and meta-analyses now demonstrate that home-based and telerehabilitation models yield outcomes comparable to inpatient and clinic-based programs for most patients, while validated risk stratification tools help us identify the patients who truly need more intensive support. Perhaps the most exciting development, and one we'll spend significant time on, is the emergence of blood flow restriction training as an evidence-based adjunct in TKA rehabilitation. Systematic reviews and meta-analyses now support its safety and efficacy for achieving meaningful strength gains at substantially lower mechanical loads than conventional resistance training, with applications spanning from postoperative day 1 all the way through late-phase rehabilitation. This modality directly addresses what many of us have experienced as the most frustrating clinical gap: that early postoperative period when patients are too weak or symptomatic for the training intensities we know they need. Meanwhile, the roles of nursing, occupational therapy, and interprofessional collaboration have been increasingly scrutinized through rigorous research, with evidence now supporting structured ERAS-based nursing protocols that reduce complications and length of stay, and a selective rather than routine approach to home health service utilization with close attention to adequate dosing when those services are prescribed. This course synthesizes the most current evidence across 7 content modules, drawing from clinical practice guidelines issued by the American Academy of Orthopedic Surgeons, the American Physical Therapy Association, the ERAS Society, the American College of Rheumatology, the American Occupational Therapy Association, and the European Knee Associates, along with recent systematic reviews, meta-analyses, and randomized controlled trials published between 2022 and 2025. Whether you're a physical therapist, occupational therapist, nurse, or allied health professional involved in perioperative and rehabilitative TKA care, each module integrates discipline-specific perspectives because the evidence is crystal clear. Interdisciplinary collaboration isn't just nice to have, it's essential for optimizing outcomes across the care continuum, from preoperative optimization through return to work and sport. Here's what you'll be able to do by the end of this course. First, identify the key components of enhanced recovery after surgery protocols that reduce perioperative complications following total knee arthroplasty. Second, differentiate among robotic-assisted surgery, cementless fixation, and alignment strategies based on patient selection criteria in TKA. Third, compare the clinical outcomes of inpatient, outpatient, home-based, and telerehabilitation settings for post-TKA recovery. Fourth, select evidence-based exercise prescription parameters for each phase of TKA rehabilitation. Fifth, recognize the indications, contraindications, and safety considerations for blood flow restriction training in TKA rehabilitation. Sixth, describe the distinct roles of physical therapy, occupational therapy, and nursing within multidisciplinary TKA rehabilitation. And seventh, classify the criteria and timelines for return to activity, sport, and work following primary and revision TKA. Let's dive into Module 1, Perioperative Optimization and Enhanced Recovery After Surgery Protocols. If there's one message I want you to take from this module, it's this: successful TKA rehabilitation starts well before the surgical incision. Enhanced recovery after surgery protocols integrate preoperative optimization, standardized perioperative care, and structured postoperative rehabilitation into a unified pathway. And as we mentioned, this approach has been endorsed as the gold standard by the European Society of Sports Traumatology, Knee Surgery, and Arthroscopy. The ERAS Society Consensus Statement for total hip and knee replacement covers 17 topic areas spanning preoperative patient education, anesthetic technique optimization, transfusion strategy, opioid-sparing multimodal analgesia, and early mobilization. These protocols represent a true paradigm shift from traditional perioperative management, and they demand evidence-based standardization across the entire care continuum. So, how much difference do these protocols actually make? The clinical impact has been demonstrated through rigorous multi-center investigation. A multi-center prospective randomized controlled trial published in 2025 showed that ERAS pathway implementation cut hospital length of stay from an average of 8.17 days down to 5.902 days, with significantly less postoperative pain and a dramatic reduction in postoperative nausea and vomiting, just 2.6% compared to 24.7% in the conventional care group. And here's what makes it even more compelling. The relationship between ERAS adherence and outcomes follows a dose-response pattern. In other words, the more closely your team follows the protocol, the better your patients do. The POWER2 study published in JAMA Surgery demonstrated exactly this. Patients in the highest adherence quartile experienced significantly fewer adverse events than those in the lowest quartile, and adherence above 62.5% was independently associated with reduced complications. A 2024 systematic review and meta-analysis encompassing 407 studies and over 76,000 patients confirmed that ERAS protocols significantly shortened length of stay by approximately 2.65 days, reduced transfusion rates, and lowered 30-day mortality, all without increasing complications or readmission rates. The American Academy of Orthopedic Surgeons strongly recommends perioperative glucose control targeting, fasting glucose below 106 milligrams per deciliter, and hemoglobin A1C below 6.5%. Why? Because hyperglycemia leads to less favorable postoperative outcomes and higher complication rates. The American College of Rheumatology and American Association of Hip and Knee Surgeons Clinical Practice Guideline, what we'll call the ACRA-HKS guideline, conditionally recommends actually delaying total joint arthroplasty to improve glycemic control in patients with poorly controlled diabetes. That's a strong statement, and it underscores how seriously we need to take this. A 2025 randomized controlled trial demonstrated that perioperative basal bolus insulin therapy significantly reduced blood glucose variability compared to oral hypoglycemics in non-insulin-dependent diabetic TKA patients. The coefficient of variation, essentially a measure of how much blood sugar levels bounce around, was 15.6% versus 24.6%. For us as rehabilitation clinicians, the practical takeaway is that blood glucose monitoring during therapy sessions, close observation of wound healing, and individualized progression based on wound status and glycemic control are all essential when we're working with diabetic TKA patients. Moving to obesity and weight management, the ACRA-HKS 2023 guideline conditionally recommends proceeding to total joint arthroplasty without delaying for weight reduction in patients with a body mass index of 35 to 39, because pain and function improvements are similar regardless of obesity status at that threshold. The AOS notes no difference in functional scores between patients with a BMI below 30 and those with a BMI of 30 to 39.9. But once we hit morbid obesity, BMI at or above 40, surgical site infection risk goes up significantly, and preoperative weight management becomes important. Here's a critical timing detail that surprised many clinicians. Weight loss should be achieved at least 9 months before TKA to decrease infection risks. Patients who achieved their BMI reduction less than 9 months before surgery actually had increased periprosthetic joint infection risk. On a promising note, glucagon-like peptide 1 receptor agonists, GLP-1 receptor agonists, have emerged as a powerful optimization strategy. A 2025 meta-analysis of over 346,000 patients found that GLP-1 receptor agonist use was associated with lower 90-day periprosthetic joint infection risk and decreased readmission rates, though an elevated myocardial infarction risk was noted in TKA specifically. Now, anemia, smoking, and opioid optimization. Preoperative hemoglobin should be brought to at least 13 grams per deciliter to reduce transfusion risk. A 2025 meta-analysis found that high-dose intravenous iron supplementation significantly decreased blood transfusion rates. The odds ratio was 0.403, meaning patients who received high-dose IV iron were less than half as likely to need a transfusion, and it also reduced the post-operative hemoglobin drop at 2 to 6 weeks following TKA. The AAOS guidelines recommend smoking cessation before TKA because smoking leads to higher complications, lower functional scores, and surgical site infections. The evidence is clear that just 4 weeks of tobacco abstinence meaningfully reduces major pulmonary and wound healing complications. The AAOS also provides a moderate recommendation for getting patients off preoperative opioids. And the Non-Opioids Prevent Addiction in the Nation Act, effective 2025, now provides separate Medicare reimbursement for non-opioid pain treatments, a practical policy change that supports this clinical goal. On the infection prevention front, a meta-analysis found that preoperative nasal Staphylococcus aureus decolonization cut surgical site infection rates from 2.0% down to 0.8%, with even greater benefit when combined with skin antisepsis. The European Society of Clinical Microbiology and Infectious Diseases 2024 guidelines recommend screening for Staphylococcus aureus before orthopedic surgery and decolonization with intranasal mupirocin plus chlorhexidine bath for 5 days. For nutritional optimization, we should target vitamin D levels above 30 nanograms per deciliter and albumin above 3.5 grams per deciliter. And the dosing matters. High-dose vitamin D loading of 50,000 international units weekly for 4 weeks, followed by 2,000 international units daily corrected deficiency in 73.3% of patients, compared to just 42.4% with low-dose supplementation alone. Let's talk about prehabilitation, structured exercise programs conducted before surgery, because this is one of the most actionable things we can offer our patients. The evidence is strong. A 2025 meta-analysis of 29 randomized controlled trials encompassing 2,157 participants found that preoperative rehabilitation yielded significant improvements in WOMAC function scores, that's the Western Ontario and McMaster University's Osteoarthritis Index Function Subscale, at midterm follow-up, and also significant improvements in WOMAC pain scores. Here's what's particularly interesting. Home-based telerehabilitation consistently outperformed clinic-based approaches. An overview of systematic reviews published in 2025 confirmed that prehabilitation reduces complication rates, improves strength, and boosts objective function, though the effects were generally confined to the first 6 months postoperatively. What that tells us is that prehabilitation primarily accelerates early recovery rather than changing the ultimate destination. But that acceleration matters enormously for patient experience, resource utilization, and early return to function. So what should a good prehabilitation program look like? It should be multi-component. Exercise-based prehabilitation typically includes progressive resistance training targeting the quadriceps, hamstrings, and hip musculature, aerobic conditioning via walking, cycling, or aquatic exercise, and flexibility and range of motion exercises to maintain or improve preoperative joint mobility. Programs lasting 4 to 8 weeks with 3 sessions per week have demonstrated the strongest evidence for post-operative benefit. Home-based programs with remote monitoring have emerged as the preferred delivery model because they overcome real-world barriers, clinic access, transportation, scheduling, while maintaining or even exceeding the outcomes of supervised clinic-based programs. For patients with elevated pain, catastrophizing, or anxiety, adding pain neuroscience education and psychological preparation components to the exercise-based program can enhance outcomes, addressing both the physical and psychological readiness for surgery. And don't overlook patient education. It should be comprehensive and multimodal. Educational interventions utilizing information technology devices were significantly more effective in improving postoperative pain and range of motion than traditional methods alone. Effective preoperative education encompasses surgical procedure explanation, realistic outcome expectations, postoperative rehabilitation protocols and self-management strategies, pain management techniques including cryotherapy application and medication timing, and warning signs requiring medical attention. When you combine physical prehabilitation with psychological preparation and comprehensive education, you create a unified preoperative optimization approach that addresses the biological, psychological, and educational domains simultaneously, maximizing the patient's readiness for surgery and their capacity to actively participate in post-operative rehabilitation. Now let's discuss multimodal analgesia. And this is something every member of the rehabilitation team needs to understand because it directly affects what happens in your therapy sessions. Multimodal analgesia has become the standard of care for TKA, reflecting a fundamental shift away from opioid dominant pain management toward combinations of non opioid systemic medications, regional anesthesia techniques, and local infiltration that collectively provide superior pain control with fewer adverse effects. The Prospect Working Group, an international collaboration of anesthesiologists and surgeons, recommends acetaminophen and NSAIDs or COX inhibitors as baseline systemic therapy, combined with a single-shot adductor canal block for regional analgesia and periarticular local infiltration analgesia, incorporating a mixture of local anesthetic ketorolac and epinephrine, together with a single intraoperative dose of intravenous dexamethasone for its anti-inflammatory and analgesic properties. The beauty of this combination is that it targets multiple pain pathways simultaneously, providing additive or synergistic analgesia while reducing reliance on any single agent. A 2025 Bayesian network meta-analysis, an advanced statistical method that compares multiple treatments simultaneously across many studies, evaluated 7,199 patients across 53 randomized controlled trials. It compared the relative effectiveness of regional and local analgesic techniques and found that continuous intra-articular analgesia, local infiltration analgesia, and posterior capsule infiltration delivered the best pain control on postoperative days 1 through 3. One important shift you should know about: the adductor canal block has largely replaced the femoral nerve block as the preferred peripheral nerve block. Why? Because it preserves quadriceps motor function, which means earlier mobilization and earlier meaningful participation in rehabilitation. As for opioids, they should be reserved as rescue analgesics. The evidence is clear. They carry significant addiction risk, hyperalgesia potential, and they fail to demonstrate clinical benefit over comprehensive multimodal alternatives when adequate non-opioid analgesia is in place. Multimodal protocols are now reducing opioid consumption by 40% to 60% compared to traditional opioid-based regimens. What about cryotherapy? The 2025 Cochrane review of 22 randomized controlled trials, the most comprehensive evaluation to date, found low certainty evidence that cryotherapy may reduce blood loss by approximately 264 milliliters and slightly improve pain at 48 hours, but concluded that the benefits may be too small to justify routine use as a standalone therapy. That said, cryotherapy remains commonly used as part of a multimodal approach, and patient education on proper application technique, duration, and skin protection should be provided by nursing and rehabilitation staff as part of the ERAS-based discharge protocol. Here's the key point for every clinician in this course: be familiar with the entire multimodal analgesia protocol used at your institution. The timing of your therapy sessions relative to medication administration can significantly influence pain levels, exercise tolerance, and functional progress during those critical acute and subacute phases. Now I want to talk about something that doesn't always get the attention it deserves: psychological screening and optimization. This is an area of growing importance, and it has implications for every member of the interdisciplinary care team. The evidence is compelling. Psychological factors are strong, independent predictors of TKA outcomes. A foundational meta analysis demonstrated that preoperative pain catastrophizing, depression, and anxiety are significantly associated with worse postoperative pain, worse functional outcomes, and lower patient satisfaction. A 2025 systematic review confirmed that preoperative pain catastrophizing and resilience both correlate with function and pain outcomes following TKA. Resilience, the ability to bounce back from adversity, actually predicts better postoperative knee function and general physical health. That's an important nuance. Psychological optimization isn't just about reducing risk factors, it's also about strengthening protective factors like resilience. Can we actually change these trajectories with intervention? Yes, and the evidence is getting stronger. A level I randomized controlled trial, the highest level of clinical evidence, demonstrated that perioperative psychological intervention by a psychiatrist improved patient satisfaction from 62.5% to 88.0% in depressed TKA patients. The odds ratio was 4.40, meaning depressed patients who received the psychological intervention were more than 4 times as likely to report satisfaction. The trial also produced significant improvements in depression scores and WOMAC scores at 2 years. This is the strongest evidence we have that psychological intervention can meaningfully improve arthroplasty outcomes in psychologically vulnerable patients. And here's what's encouraging for rehabilitation professionals. You don't necessarily need a separate mental health referral to make a difference. Preoperative, home-based multimodal physiotherapy incorporating pain neuroscience education reduced pain catastrophizing and improved self-efficacy, dynamic balance, and walking speed in high catastrophizing patients, demonstrating that psychological interventions can be effectively delivered within physical rehabilitation contexts. A 2024 systematic review looking at depression interventions in total joint arthroplasty patients, even those without a formal depression diagnosis, found that cognitive-based psychotherapy and enhanced perioperative support had the best evidence for improving depression scores, pain, and function. This extends the potential benefits beyond patients with diagnosed psychiatric conditions to the much larger population experiencing subclinical psychological distress. Even brief interventions matter. A single 15-minute mindfulness-based session improved pain, anxiety, and function at 6 weeks postoperatively. These findings support routine preoperative psychological screening using validated instruments like the Pain Catastrophizing Scale, Patient Health Questionnaire 9, Generalized Anxiety Disorder 7, and Brief Resilience Scale. And as rehabilitation professionals, we play a key role in this process. We often have the most sustained contact with TKA patients throughout recovery, which puts us in an ideal position to identify emerging psychological barriers. Let's move into Module 2, Surgical Advances in Total Knee Arthroplasty. Now, we don't perform surgery, but a thorough understanding of what's happening in the operating room is essential for informed clinical reasoning, setting appropriate postoperative expectations, and communicating effectively with the surgical team. The past several years have brought transformative developments in robotic-assisted surgery, fixation methods, alignment strategies, and patient selection that directly influence the rehabilitation trajectories and functional outcomes we manage every day. Let's start with robotic-assisted TKA, which has become the most widely discussed technological advancement in contemporary knee arthroplasty. These systems use preoperative CT scans or intraoperative imaging to create three-dimensional bone models, enabling real-time surgical guidance for bone cuts that conform to a preoperative plan. The precision is impressive. A 2025 meta-analysis of 20 prospective studies encompassing 2,421 patients found superior radiological precision with improved coronal alignment, joint line restoration, and sagittal tibial positioning, and significantly fewer alignment outliers compared to conventional TKA. Complication rates were significantly lower in the robotic-assisted group, 11.5% versus 16.7%, with an odds ratio of 0.62. That means patients who received robotic-assisted surgery had about 38% lower odds of complications, and this finding was statistically significant. But here's the question that matters most to us. Does this radiological superiority translate to meaningful clinical differences for our patients? And the honest answer is, it's nuanced. Clinical outcome differences between robotic assisted and conventional TKA remain modest. The same meta analysis found improved range of motion favoring robotic assisted TKA, but no significant differences in Oxford Knee Score, COOS Forgotten Joint Score, or EQ5D quality of life measures. A large single center study comparing robotic arm assisted TKA with imageless computer navigation found that robotic assistance was associated with fewer component outliers, lower transfusion rates, shorter length of stay, and fewer manipulations under anesthesia. Though the clinical significance of these differences at longer follow up remains to be determined. Where it does seem to matter for our daily practice, a 2025 prospective study using daily remote patient monitoring found that robotic assisted TKA patients had significantly less early postoperative pain, 3.6 versus 4.2 on the visual analog scale, used 10 fewer morphine milligram equivalents per day, and stopped opioids 6 days sooner than conventional TKA patients. Those early recovery advantages can make a real difference in how quickly we can engage patients in meaningful rehabilitation. Who benefits most? Secondary analysis of randomized controlled trial data identified that male patients, those younger than 67 years, patients with worse preoperative function, and those with lower preoperative quality of life derive the greatest benefit from robotic assistance. The technology seems to provide the most value where precise alignment restoration is most challenging. The National Institute for Health and Care Excellence concluded that more high-quality evidence is needed before routine adoption, and the current evidence doesn't support universal implementation. For us, the practical takeaway is this. Robotic-assisted TKA patients may demonstrate faster early recovery milestones and potentially reduced pain and opioid requirements during initial rehabilitation sessions, but long-term functional expectations are equivalent to conventional TKA. Now let's look at the evolving debate between cementless and cemented fixation. This conversation has changed considerably with improvements in implant surface technology. We now have highly porous metals and hydroxyapatite coatings that promote biological osseointegration, the process by which bone grows directly into the implant surface to create a stable bond. A 2025 systematic review of 27 randomized controlled trials found that contemporary cementless TKA demonstrates survivorship of 93.7% to 100% at 2 to 17 years, comparable to cemented TKA at 90% to 100%. Of 24 studies evaluating patient-reported outcomes, 20 showed no significant difference between groups, while 4 actually showed improved outcomes for cementless TKA. A separate 2025 meta-analysis of 68 studies found that cementless implants may offer improved survival in patients under 60 years for up to 14 years, with shorter operating times, shorter hospital stays, fewer complications, and lower deep vein thrombosis incidence, though higher early migration was observed at 1 and 5 years. So what does this mean for our rehabilitation planning? Cementless fixation relies on initial press-fit stability, followed by biological ingrowth, which occurs over 6 to 12 weeks. While most contemporary cementless designs allow immediate full weight bearing as tolerated, some surgeons may prescribe more conservative weight bearing restrictions, particularly with newer implant designs or in patients with poor bone quality. The key action item: communicate directly with the surgical team about specific weight bearing protocols for each patient. Don't assume. Cementless fixation tends to be favored in younger, more active patients who are expected to outlive the prosthesis and may need future revision, since cementless designs may preserve more bone stock. Patients with osteoporosis, diabetes, or other conditions affecting bone quality may be better served by cemented fixation, which provides immediate stable fixation independent of biological ingrowth. Let's turn to one of the most debated topics in TKA, alignment strategy. Specifically, kinematic versus mechanical alignment. This debate has been going on for over a decade. Proponents of kinematic alignment argue that restoring the knee's pre-disease constitutional alignment more closely replicates normal joint kinematics and produces a more natural-feeling knee. Mechanical alignment, the traditional approach, targets a neutral mechanical axis with the goal of equalizing the load distribution from side to side across the tibial plateau to maximize implant longevity. So which is better? A 2025 meta-analysis of 12 randomized controlled trials directly comparing these approaches found no clinically important benefit favoring kinematic over mechanical alignment when assessed using minimum clinically important differences for validated outcome measures. And the longest follow-up data we have, a 10-year randomized trial, found no difference in any patient-reported outcome measure between the two approaches, with similar revision-free survivorship at 96% versus 91%. The authors explicitly concluded that mechanical alignment remains the reference standard for TKA. That said, modern alignment strategies have evolved beyond this binary debate. A comprehensive review noted that minor deviations of plus or minus 3 degrees from neutral mechanical alignment do not significantly impact long-term implant survivorship, supporting an approach that allows individual anatomic variation within a safe zone rather than demanding rigid adherence to neutral. There's some evidence that patients with severe varus deformity exceeding 10 degrees may benefit more from kinematic alignment, while obese patients with BMI above 30 may achieve better outcomes with mechanical alignment. A 2025 meta-analysis using Bayesian network analysis confirmed no significant differences between alignment philosophies overall, while noting that restricted kinematic alignment, which applies kinematic principles within defined boundaries, may represent a promising compromise. The bottom line for rehabilitation professionals, alignment strategy selection does not appear to significantly alter rehabilitation protocols, progression timelines, or long-term functional expectations. Base your rehabilitation plans on individual patient recovery, not alignment philosophy. Let me briefly cover minimally invasive surgery, patient-specific instrumentation, and the important topic of outcome predictors. Minimally invasive techniques for TKA use smaller incisions and reduced soft tissue dissection, aiming to preserve the quadriceps mechanism and facilitate faster recovery. Meta-analyses have demonstrated shorter hospitalization and faster early recovery, but these techniques are more technically demanding and have been associated with higher wound complication rates, particularly with less experienced surgeons. Patient-specific instrumentation, individualized cutting guides manufactured from preoperative imaging, has been developed to improve alignment accuracy and reduce surgical time. Evidence shows improved alignment accuracy in some studies and reduced intraoperative blood loss, but no consistent functional outcome advantage over conventional instrumentation. For us as rehabilitation professionals, these technologies are most relevant in terms of understanding the potential for variable early recovery patterns based on surgical approach and the importance of communication with the surgical team regarding any approach-specific precautions or weight-bearing protocols. Now, understanding what predicts poor outcomes is incredibly valuable for our clinical decision-making. A 2025 award-winning study based on 5-year follow-up data identified that musculoskeletal comorbidities including back pain, contralateral knee pain, and ipsilateral hip pain are potentially modifiable factors that independently predict less improvement in pain and function. This supports preoperative optimization programs that address the entire kinetic chain, not just the operative knee in isolation. Other modifiable predictors of poor outcomes include obesity with BMI at or above 40, depression and anxiety, chronic back pain, poor sleep quality, and preoperative opioid use. Non-modifiable predictors include age at or above 80 years, diabetes, American Society of Anesthesiologists classification at or above 3, and history of substance abuse, which carries a particularly alarming hazard ratio of 4.68, meaning those patients are nearly 5 times more likely to experience poor outcomes. One more important topic, unicompartmental versus total knee arthroplasty. The AAOS guidelines support unicompartmental arthroplasty for patients with predominantly medial compartment osteoarthritis, with evidence showing improved patient-reported and functional outcomes in the short term. A matched comparison at 5 or more years found unicompartmental patients had significantly higher forgotten joint scores and lower pain scores with excellent survivorship. And here's something that challenges conventional wisdom. A 2025 study found that 68% of patients who had successful unicompartmental outcomes would have been contraindicated by traditionally published selection criteria. That suggests the indications for unicompartmental arthroplasty may be broader than we previously recognized. Rehabilitation professionals should be aware that unicompartmental patients generally demonstrate faster early recovery, better early range of motion, and higher activity levels compared to TKA patients, which may influence rehabilitation intensity and progression expectations. Welcome to Module 3, Rehabilitation Setting Selection and Discharge Planning. This module may challenge some of what you've traditionally practiced, and that's the point. The comparative effectiveness of inpatient, outpatient, and home-based rehabilitation for primary TKA has been rigorously evaluated, and the evidence now strongly favors direct home discharge for the majority of patients. The APTA guideline recommends direct home discharge after TKA whenever possible, because inpatient rehabilitation has not demonstrated superior functional outcomes or reduced complications at 6 months or 2 years. The landmark Hi-Ho randomized clinical trial, published in JAMA, randomized 165 TKA patients to either inpatient rehabilitation followed by home care or home care alone. The results? No difference in the 6-minute walk test, just a 1.01 meter difference. No difference in Oxford knee score, just 2.06 points. No difference in quality of life at 26 weeks. A systematic review and meta-analysis published in JAMA Network open synthesized evidence from 6 studies involving 917 participants and found no clinically important difference between clinic-based and home-based programs for mobility at 10 weeks or for patient-reported pain, function, or quality of life. Here's a finding that may surprise you. Supervised outpatient rehabilitation does not confer superior outcomes over home-based protocols for most patients. A 2023 systematic review and meta-analysis actually demonstrated that at 52-week follow-up, unsupervised groups showed significantly better results on the 6-minute walk test and timed up and go test compared to supervised groups. Counterintuitive, right? But it likely reflects the higher frequency and self-directed nature of home exercise. Patients exercise more often when they're not waiting for their next clinic appointment. Even among patients at elevated risk of poor outcomes, a BMJ-published randomized controlled trial found the between-group difference in Oxford knee score was only 1.91 points at 52 weeks, not clinically meaningful. A systematic review of 53 randomized controlled trials concluded that various rehabilitation programs after TKA lead to comparable improvements in pain, range of motion, and activities of daily living. And discharge to inpatient rehabilitation facilities? It's associated with higher costs without improved functional outcomes for uncomplicated TKA, and meta-analytic evidence suggests it may paradoxically increase readmission rates. If the previous slide made you rethink inpatient rehab, this one should make you think seriously about telerehabilitation as a first-line option. Home-based telerehabilitation has emerged as a cost-effective modality supported by a rapidly growing evidence base. A systematic review of 9 studies involving 1,944 patients found comparable long-term outcomes in pain, mobility, and function, with home-based telerehabilitation actually yielding superior knee range of motion compared to hospital-based outpatient rehabilitation. A home-based, remote clinician-controlled therapy device demonstrated superior outcomes at all time, points through 12 weeks, with significantly fewer cases of arthrofibrosis requiring manipulation under anesthesia, 1.48% versus 4.44%. Think about that. Consistent clinician-monitored exercise at home may actually improve adherence and outcomes compared to intermittent clinic visits. The most comprehensive evaluation to date, a 2025 meta-analysis of 19 randomized controlled trials, found that telerehabilitation produced significant improvements in total WOMAC scores, KU scores, and timed up-and-go times, with a mean improvement of 2.73 seconds compared to conventional rehabilitation. And the cost story is compelling. The Veritas randomized controlled trial reported median 12-week costs of $1,050 for telerehabilitation versus $2,805 for conventional rehabilitation, with lower rehospitalization rates at 2.9% versus 7.8%, and outcomes that were non-inferior, meaning just as good, across all functional measures. These findings position telerehabilitation as a viable primary rehabilitation modality, not a compromise or a cost-cutting substitute, with particular advantages for patients in rural or underserved areas, those with transportation barriers, and working-age individuals who benefit from the scheduling flexibility. Now, the shift toward direct home discharge is exciting, but it creates an important responsibility. We need validated tools that can accurately identify which patients will thrive with home-based rehabilitation and which ones truly need more intensive support. Several tools have been developed for this. The risk assessment and prediction tool, the RAPT score, uses patient age, gender, walking distance, use of gait aid, community support, and living arrangements to predict discharge destination, length of stay, and postoperative mobility. Scores of 8 or above are most sensitive and specific for home discharge, and the tool has a C statistic of 0.72 to 0.74, indicating good predictive accuracy. The plan score, calculated preoperatively, and the AMPAC 6-click score, assessed on postoperative day 1, provide complementary prediction with C statistics of 0.72 to 0.81, good to very good accuracy. When both tools agree on home discharge, 98% of patients are successfully discharged home with lower readmission rates of 5.1% to 7.0%. The cumulated ambulation score on postoperative day 1 also has value. Scores of 11 or above are associated with 75.9% home discharge, while scores below 11 predict 85.7% discharge to a rehabilitation facility. Here's a finding that should reshape how we think about therapy referral. The Kappa non-randomized controlled trial established that over half of TKA patients can successfully self-direct their rehabilitation without supervised physical therapy, and their outcomes are equivalent to those receiving formal outpatient rehabilitation. The criteria for referral to supervised therapy at 2 weeks are straightforward: knee flexion below 90 degrees, extension lacking more than 10 degrees, or patient dissatisfaction with progress. Only 47% of patients met those criteria, and after an average of just 4 additional supervised sessions, outcomes equalized at 4 months. That's a game changer. It suggests most supervised therapy demand may be addressable with brief targeted intervention rather than lengthy rehabilitation courses. A separate validated 4-variable predictive model using age, gender, motivation for outpatient therapy, and reliable transportation achieved excellent predictive accuracy, a C statistic of 0.86 to 0.91 for determining home health versus outpatient rehabilitation need. Interestingly, lack of motivation for outpatient therapy was the strongest predictor of home health service need. Predictors of inpatient rehabilitation discharge include bilateral procedure, living alone, older age above 75, female sex, and obesity. When home health services are indicated, and for the right patients, they absolutely should be, the evidence gives us clear guidance on how to make them effective. Timely initiation is critical. Delayed onset of home health care following hospital discharge is independently associated with reduced probability of self-care improvement, lower mobility gains, and increased 90-day hospital readmission rates. Don't let your patients fall through the cracks during the transition home, and the dosing matters enormously. There's a robust dose-response relationship for home health physical therapy intensity. 6 to 9 visits produce approximately 25% greater improvement in activities of daily living compared to 5 or fewer visits. 10 to 13 visits yield approximately 40% improvement, and 14 or more visits produce approximately 50% greater improvement. This isn't trivial. Poor recovery of activities of daily living function during home health episodes is associated with a 77% increased risk of subsequent hospitalization. That makes adequate rehabilitation dosing a patient safety issue, not just a quality benchmark. But here's the flip side, and it's important. A large retrospective analysis found that routine home health care in Medicare-age TKA patients was actually associated with increased early emergency department visits, higher readmission rates, and additional costs of $1,727 per episode compared to self-care discharge. This doesn't mean home health services are harmful. It means that blanket referral of every TKA patient to home health is neither cost-effective nor clinically beneficial. The evidence-based approach is selective referral using validated risk assessment tools, directing home health resources toward patients who will genuinely benefit. Those with functional limitations, limited social support, challenging home environments, or medical comorbidities that complicate self-directed recovery. And remember, mobility status and home environment factors should be assessed together when making discharge decisions because their interaction influences readmission risk more strongly than either factor alone. Let me pull together the key implications from this module and look at where rehabilitation delivery is heading. The collective evidence supports several clear conclusions. First, direct home discharge is appropriate and recommended for the majority of uncomplicated TKA patients. The APTA guideline explicitly endorses this. Second, telerehabilitation and home-based programs produce outcomes that are at least as good as, and sometimes better than, clinic-based rehabilitation at substantially lower cost and with greater patient convenience. Third, validated risk stratification tools should be used systematically to identify the minority of patients who need more intensive supervision or inpatient rehabilitation. Fourth, when home health services are prescribed, timely initiation and adequate visit intensity, at least 6 visits, are essential for meaningful functional recovery. Fifth, self-directed rehabilitation with standardized exercise protocols works for over half of TKA patients, with brief, targeted intervention available for those who don't meet functional criteria at follow-up. These findings collectively represent a significant shift toward individualized, stratified rehabilitation approaches that optimize resource allocation while maintaining or improving outcomes. The delivery landscape is also evolving in exciting ways. Remote patient monitoring using wearable sensors and smartphone applications now enables clinicians to track daily step counts, range of motion progress, exercise adherence, and gait parameters in real time, catching patients who are falling behind expected recovery trajectories before small problems become big ones. The integration of remote monitoring with telerehabilitation creates a powerful hybrid model. Technology-enhanced rehabilitation using gamified exercise applications, virtual reality-guided movement training, and sensor-based biofeedback systems is showing promise for improving exercise adherence and motivation. Stratified care pathways, like the Kappa model, represent a paradigm shift from uniform rehabilitation prescriptions toward individualized care allocation based on patient-specific recovery trajectories. In this model, every TKA patient receives a standardized home exercise program and gets assessed at a predefined follow-up time point. Only those who don't meet functional criteria get referred for additional supervised rehabilitation, while those meeting criteria continue self-directed exercise. The evidence supporting this stratified approach is compelling. Over half of TKA patients can successfully self-direct their rehabilitation without supervised physical therapy while maintaining excellent outcomes. And among those referred for additional therapy, brief targeted intervention of 4 sessions on average is sufficient to equalize outcomes with self-directed groups at 4 months. This challenges the traditional model of prescribing a uniform course of outpatient physical therapy for every TKA patient and supports a more efficient, patient-centered approach to rehabilitation resource allocation. Now we're into Module 4, Phase-Based Exercise Prescription and Progressive Rehabilitation. This is the core of what many of you do every day, so let's make sure the evidence is guiding our decisions. Early mobilization is the cornerstone of post-operative TKA rehabilitation and a central component of ARAS protocols. The APTA Clinical Practice Guideline recommends initiating rehabilitation within 24 hours of surgery, with a strong recommendation for motor function training that includes balance, walking, and movement symmetry. And the evidence for same-day mobilization is increasingly compelling. A study comparing same-day physical therapy on post-operative day 0 with initiation on post-operative day 1 demonstrated significantly improved outcomes. More steps walked on the first post-operative day, 347.6 versus 167. 4 feet, shorter length of stay at 2.3 versus 3.1 days, less opioid use, and higher functional independence at discharge. A Cochrane review found silver-level evidence that early multidisciplinary rehabilitation improves outcomes at the activity and participation levels, with more rapid achievement of functional milestones. For perspective, the FIM ambulation scores showed a number needed to treat of 3, meaning for every 3 patients who receive early multidisciplinary rehabilitation, 1 additional patient achieves a meaningful improvement in ambulation. The review also found shorter hospital stays and fewer complications. The acute phase, the first 2 weeks postoperatively, focuses on pain management, edema control, early range of motion restoration, and basic functional mobility. Exercise during this phase emphasizes low-intensity, high-frequency movements, ankle pumps for venous return and edema management, isometric quadricep sets, supine straight leg raises, seated knee flexion and extension with intolerance, and gentle patellar mobilization. The key is frequency. Patients should be performing these exercises multiple times daily. The Power 2 study confirmed that early mobilization was associated with reduced complications, an odds ratio of 0.6e, meaning 40% lower odds, providing level 1 evidence for nursing initiated mobilization protocols beginning on postoperative day 0. For therapeutic adjuncts, the APTA guideline gives a moderate recommendation for neuromuscular electrical stimulation, NMES, as it improves quadriceps strength, gait, and patient reported outcomes. Consider it especially for patients demonstrating significant quadriceps inhibition or inability to generate adequate voluntary contraction. On the other hand, the APTA gives a moderate recommendation against continuous passive motion, or CPM. The conclusion is clear. CPM should not be used for primary uncomplicated TKA. It doesn't improve range of motion, pain, function, or quality of life beyond standard rehabilitation. This is a significant departure from historical practice where CPM was standard of care. ERAS-based nursing care during this phase includes knee positioning in 30 to 90 degrees of flexion during the first 7 days, cryotherapy application, and deep vein thrombosis prophylaxis education. The subacute phase, typically weeks 2 through 8, is where the real strengthening work begins, and it's critical that we get the dosing right. Here's what we're up against. Quadriceps weakness often persists for 1 to 2 years postoperatively and represents the primary functional limitation following TKA. A narrative review of resistance exercise training for TKA rehabilitation emphasized that persistent quadriceps atrophy of 50% to 60% relative to the contralateral limb is common in the early postoperative period. And here's the sobering part. Without structured progressive resistance training, significant strength deficits may remain permanent. The evidence supports initiating resistance training at 70% to 80% of 1 repetition maximum for 3 to 4 sets of 8 to 12 repetitions, performed at a minimum of 3 times per week for at least 8 weeks. This dosing follows American College of Sports Medicine guidelines and has been adapted specifically for TKA patients. Exercise selection should target the entire lower extremity kinetic chain, with particular emphasis on the quadriceps, hamstrings, hip abductors, and calf musculature. Open chain exercises like seated knee extensions and prone hamstring curls allow isolated muscle strengthening with controlled range of motion. Closed chain exercises like mini squats, step ups, leg presses, and calf raises integrate multiple muscle groups and provide more functional loading patterns. Progress from partial to full range of motion based on tissue healing and patient tolerance, and watch for increased effusion, warmth, or pain that might signal excessive loading. Don't neglect hip abductor strengthening. Weakness here contributes to gait deviations, Trendelenburg patterns, and compensatory strategies that can perpetuate movement dysfunction well beyond the recovery period. Aerobic conditioning should happen concurrently. Cardiovascular fitness commonly declines during the perioperative period. Stationary cycling is excellent for TKA patients because it provides low-impact cardiovascular conditioning while simultaneously promoting range of motion through the pedaling arc. Start cycling when the patient achieves approximately 90 degrees of knee flexion, typically by weeks 2 to 4, with seat height adjusted to minimize the required flexion. Aquatic exercise offers buoyancy-assisted movement and multidirectional resistance, and is appropriate once wound healing is complete, typically 2 to 3 weeks for well-healed incisions. Progressive walking programs should advance from household ambulation with assistive devices to community ambulation over level and varied terrain, with intensity guided by perceived exertion of 11 to 13 on the Borg scale and cardiovascular response. Range of motion targets during this phase: at least 105 to 110 degrees of knee flexion and full extension within 0 to 5 degrees. The APTA guideline recommends supervised exercise progression with regular reassessment of range of motion, strength, functional mobility, and patient-reported outcomes using validated instruments such as the Kuth's JR, timed up and go, 30-second sit-to-stand, and 6-minute walk test. The late phase, beginning around week 8 and extending through 6 months or beyond, is where we introduce advanced strengthening and functional training to prepare patients for real-world demands. Progressive resistance exercise training remains essential because quadriceps strength deficits of 20% to 30% compared to the contralateral limb commonly persist at 6 months postoperatively. Eccentric strengthening protocols, emphasizing the controlled lengthening phase of muscle contraction, should be introduced gradually, progressing from concentric eccentric combinations to eccentric focused exercises as tolerated. Balance and sensoromotor exercises are critical for addressing the proprioceptive deficits that result from the removal of cruciate ligaments and joint mechanoreceptors during arthroplasty. Progress these from stable to unstable surfaces and from bilateral to unilateral stance. Technology is increasingly available during this phase. A 2024 meta-analysis of 14 randomized controlled trials evaluating virtual reality, augmented reality, and mixed reality rehabilitation in TKA found positive effects on range of motion and patient satisfaction, though effect sizes were moderate and the evidence base is still maturing. Sensor technologies and wearable devices for monitoring rehabilitation progress are an emerging area, with potential for real-time biofeedback on gait symmetry, weight-bearing patterns, and activity levels. Throughout the late phase, activity recommendations should be individualized based on implant type, surgical approach, bone quality, and patient goals, always working toward the ultimate aim of restoring functional independence and facilitating safe return to the activities our patients care about most. Before we leave this module, let's address modifications for special populations and the principles of criteria-based progression. Revision TKA patients need modified rehabilitation approaches. Recovery trajectories are slower and functional outcomes may be more limited than after primary TKA. A 2023 systematic review found no specific evidence-based rehabilitation protocols for revision TKA. That's an important gap that means we have to rely on clinical judgment guided by surgical factors and general rehabilitation principles. Anticipate reduced bone quality, altered soft tissue integrity, potential bone grafting requiring protected weight bearing, and constraint from revision implant designs. Get specific guidance from the surgeon on weight-bearing restrictions, range of motion limits, and any revision-specific precautions. The general principles mirror primary TKA, but with longer timelines and more conservative advancement criteria. For patients with obesity, modifications include use of bariatric-appropriate equipment with adequate weight capacity, consideration of aquatic therapy for joint offloading during the early postoperative period, and recognition that functional milestone achievement may be delayed compared to normal weight patients. Aquatic therapy may be particularly beneficial for obese patients once wound healing is complete, as buoyancy reduces joint loading while resistance facilitates strengthening. Patients with diabetes require blood glucose monitoring before and after exercise sessions, with exercise intensity adjusted based on glycemic response. Sustained hyperglycemia above 200 milligrams per deciliter may warrant temporary modification of exercise intensity, and close attention to wound healing should be maintained throughout the rehabilitation course. Hypoglycemia risk should be assessed in insulin-treated patients, with carbohydrate availability ensured during exercise sessions. Here's a principle I want to emphasize. Stop relying on arbitrary timelines for progression. Contemporary practice emphasizes criteria-based advancement. Moving from the acute to subacute phase is appropriate when the patient demonstrates adequate wound healing without signs of infection, controlled pain that allows active exercise participation, knee flexion of at least 70 to 80 degrees, and extension within 5 to 10 degrees, independent bed mobility, and transfers with appropriate assistive device and safe household ambulation. Progression to the late phase requires demonstration of adequate strength for progressive resistance training at moderate intensity, knee flexion of at least 100 to 110 degrees, full or near full extension, independent community ambulation with or without assistive device, and ability to manage stairs safely. And measure everything. Objective outcome measurement should be performed at regular intervals throughout the rehabilitation course to guide clinical decision-making and document progress. The APTA guideline recommends the timed up and go test, 30-second sit-to-stand test, and 6-minute walk test for performance-based assessment. These should be complemented by patient-reported instruments, particularly the COOS-JR for knee-specific function and the WOMAC for comprehensive pain, stiffness, and function. Document baselines at initial evaluation and reassess at standardized intervals, 2 weeks, 6 weeks, 3 months, and 6 months postoperatively, to track trajectory and catch patients who may need modified approaches or additional intervention. Module 5 is one I'm particularly excited about: blood flow restriction training in TKA rehabilitation. If you're not already using this modality, I think the evidence will convince you to start. Blood flow restriction training, BFR training, has emerged as one of the most significant advances in musculoskeletal rehabilitation over the past decade. Here's the fundamental concept. You apply a pneumatic tourniquet or specialized cuff to the proximal limb during exercise, partially blocking venous blood return while maintaining arterial inflow. This creates a localized, low oxygen environment that triggers a cascade of powerful physiological responses: metabolic stress from lactate and hydrogen ion accumulation, cellular swelling, a surge of blood flow upon cuff release called reactive hyperemia, and systemic hormonal responses including elevated growth hormone and insulin like growth factor 1. Together, these stimulate muscle protein synthesis and hypertrophy. The remarkable part? While traditional resistance training needs loads of 60% to 80% of one repetition maximum for meaningful strength gains, blood flow restriction training achieves comparable adaptations at only 20 to 40% of one repetition maximum. That's a massive reduction in mechanical joint stress. Why does this matter so much for TKA? Think about what our early post-operative patients are dealing with: significant pain, effusion, and quadriceps inhibition that prevent them from exercising anywhere near the intensities required for traditional strength training. This creates a critical therapeutic gap during the first 4 to 8 weeks, exactly when muscle atrophy is progressing most rapidly. Blood flow restriction training bridges that gap by enabling meaningful muscle stimulation at loads that are tolerable even in the immediate post-operative period. A 2022 meta-analysis in the American Journal of Sports Medicine found that low-load BFR training produced equivalent strength gains to conventional high-load training, no significant difference between groups. But when compared to low-load exercise without blood flow restriction, adding BFR produced significantly greater strength gains. A 2025 systematic review of middle-aged and elderly patients confirmed significant improvements in both upper and lower extremity strength with low-load BFR training compared to low-load training alone. I know what many of you are thinking. What about safety? Especially in a post-operative arthroplasty population with venous thromboembolism risk? Let me walk you through the evidence. A systematic review in the American Journal of Sports Medicine, encompassing 1,632 participants in 39 studies, found no reported adverse events. None. Blood flow restriction training demonstrated a safety profile comparable to traditional low-load and high-load exercise. Now, it's critical to distinguish BFR training from intraoperative surgical tourniquet use. They're fundamentally different in occlusion pressure, duration, and clinical context. A Cochrane systematic review of tourniquet use during TKA surgery found no clinically significant benefit, but that's about full tourniquet occlusion during the surgical procedure, not the partial venous occlusion at lower pressures used in therapeutic BFR. Evidence also suggests that intraoperative tourniquet use does not appear to produce clinically meaningful differences in patient-reported outcomes, further emphasizing the distinction between surgical tourniquet application and therapeutic blood flow restriction. Specifically, in TKA rehabilitation, no adverse events have been reported in any published trial. A landmark 2025 randomized trial demonstrated that passive blood flow restriction applied from postoperative day 1 did not increase rates of deep vein thrombosis, wound complications, or cardiovascular events. The venous thromboembolism concern has been comprehensively addressed by a review examining acute changes in blood clotting factors during BFR exercise. The conclusion: while transient activation of coagulation factors does occur, the clinical significance in properly screened orthopedic surgery patients receiving standard blood clot prevention medications appears minimal. The brief, intermittent nature of BFR exercise differs substantially from the prolonged, continuous occlusion of surgical tourniquets. One important caveat: no published study to date has specifically examined wound healing or infection rates with BFR training after TKA. That's an acknowledged evidence gap, and clinicians should weigh it carefully, particularly in patients with wound healing concerns. So, how do we decide which patients are appropriate candidates? A 2022 risk stratification framework gives us a systematic screening approach. The framework categorizes patients into low, moderate, and high-risk groups based on cardiovascular, peripheral vascular, and musculoskeletal history. Absolute contraindications, conditions that rule out BFR entirely, include active or recent blood clot disease, severe peripheral vascular disease, including peripheral artery disease and venous insufficiency, active cardiovascular disease, current deep vein thrombosis or pulmonary embolism, impaired blood clotting ability, uncontrolled high blood pressure, sickle cell disease, and pregnancy. Relative contraindications, situations requiring careful clinical judgment, include a history of blood clot disease that has fully resolved, controlled high blood pressure, varicose veins, and diabetes with peripheral vascular complications. Low-risk patients can proceed with standard protocols. Moderate-risk patients should receive modified protocols with reduced pressure and duration. High-risk patients should generally be excluded. And all TKA patients receiving BFR should be on appropriate blood clot prevention medication per institutional protocol. Document your risk stratification. It belongs in the medical record. Let's get into the specifics of how to actually prescribe blood flow restriction training for your TKA patients. Several key parameters need to be individually adjusted. Cuff pressure should be set at 60% to 80% of individualized limb occlusion pressure. That's the pressure required to completely stop blood flow in that specific patient's limb. This range optimizes the balance between metabolic stress and patient tolerance. And this is important. Always measure limb occlusion pressure individually. Don't use arbitrary absolute pressures because limb circumference, tissue composition, cuff width, and blood pressure all affect what's needed for effective venous occlusion in a given patient. The most widely supported repetition scheme is the 30-15-15 protocol. That's 75 total repetitions per exercise with 30-second rest intervals between sets, performed at 20% to 30% of one repetition maximum. Sessions are typically conducted 2 to 3 times per week for 6 to 12 weeks. Keep the cuff inflated throughout all sets within an exercise and deflate between different exercises. Research comparing continuous versus intermittent blood flow restriction found comparable strength and hypertrophy outcomes, with intermittent application producing less discomfort, so either approach works depending on patient tolerance. For TKA specifically, a phased integration model gives you a structured framework. Phase 1, from post-operative day 1 through week 2, uses passive blood flow restriction, no active exercise, at 80% limb occlusion pressure. The 2025 randomized trial showed that passive BFR applied 5 times daily for 5 minutes per application from day 1 significantly preserved thigh circumference, maintained lean mass, and reduced post-operative swelling compared to sham application. Phase 2, weeks 2 through 6, combines BFR with aerobic exercise like cycling at 40% to 60% limb occlusion pressure. Phase 3, weeks 4 through 12, adds BFR to low-load resistance exercise at 60 to 80% limb occlusion pressure using the 30-15-15 scheme. Phase 4, starting at week 8, combines BFR with traditional higher load resistance training as tolerated, with the goal of transitioning fully to conventional high-load training as strength and joint tolerance allow. The prehabilitation applications of BFR are some of the most exciting findings in this area. Consider this. A landmark study demonstrated that just 6 weeks of preoperative BFR training at 30% of one repetition maximum produced a 170% improvement in knee extensor strength, compared to only 3% in the control group. Even more impressive, muscle mass was preserved above baseline at 3 months postoperatively, while the control group experienced significant atrophy. That's the power of entering surgery in a substantially better conditioned state, creating a greater reserve of muscle mass and strength to withstand the inevitable post-operative muscle breakdown. A separate 2024 randomized controlled trial confirmed that preoperative BFR exercise improved 12-month post-operative functional outcomes, including the 30-second chair stand test and gait speed, with no adverse events during prehabilitation. These findings are especially valuable for patients with significant preoperative pain that limits conventional high-load training. BFR enables meaningful strengthening at loads that produce minimal joint stress. A home-based case report even demonstrated that BFR can be safely performed at home with proper patient education and equipment. BFR is also particularly valuable for several specific TKA subpopulations. Older adults with sarcopenia, the progressive loss of muscle mass and strength with aging, are a key target group. A 2025 review confirmed that BFR can prevent and treat sarcopenia through low-load exercise that avoids heavy joint stress while producing meaningful hypertrophy and strength gains. A randomized controlled trial in sarcopenic older adults found that 12 weeks of low-load BFR at 20% to 30% of one repetition maximum produced equivalent improvements in muscle mass and strength, compared to conventional high-intensity training at 70% to 80% of one repetition maximum. Other excellent candidates include patients with significant preoperative weakness, those who can't tolerate conventional loading due to pain or instability, early postoperative patients not yet cleared for high load exercise, and patients on non weight bearing or partial weight bearing precautions. For patients with knee osteoarthritis being managed conservatively, a 2025 randomized controlled trial in the Annals of Rheumatic Diseases found significant improvements in 6-minute walk distance, timed up and go, and KOOS pain scores with BFR training, supporting its use as a preoperative optimization strategy even before the decision for surgery. BFR has also been shown to reduce pain perception during exercise, potentially through activation of the body's own pain relief pathways, which may further enhance exercise tolerance in pain-limited patients. Let's wrap up this module with the practical nuts and bolts of implementing BFR in your clinic. Successful clinical implementation of blood flow restriction training requires appropriate equipment, clinician training, and systematic patient screening and monitoring protocols. Pneumatic blood flow restriction devices with automatic limb occlusion pressure measurement capabilities are preferred over elastic wraps or manual cuffs, as they enable precise, reproducible pressure application and individualized dosing based on measured limb occlusion pressure rather than arbitrary absolute pressures. The width of the cuff influences the pressure required for effective occlusion. Wider cuffs require lower absolute pressures to achieve the same relative occlusion, and most research has utilized cuffs in the 10 to 12 centimeter width range for the lower extremity. Clinicians should receive formal training in blood flow restriction principles, equipment operation, risk stratification using the published framework, and emergency procedures before implementing this modality in clinical practice. Exercise selection during blood flow restriction training should prioritize large muscle group movements when possible, though single joint exercises are appropriate for patients with limited functional capacity. Common lower extremity exercises used with blood flow restriction in TKA rehabilitation include straight leg raises, seated knee extensions, leg presses, body weight squats to available range, calf raises, and stationary cycling. The exercise should be performed within the prescribed 30-15-15 repetition scheme, with the cuff inflated throughout all sets of a given exercise and deflated for a minimum of 1 to 2 minutes between different exercises to allow blood flow to return. Patient monitoring during BFR exercise should include assessment of perceived exertion, pain levels, skin color and temperature below the cuff, and any symptoms of excessive discomfort, numbness, or tingling that would warrant immediate cuff deflation. All sessions should be documented, including cuff pressure as a percentage of limb occlusion pressure, exercises performed, repetitions completed, patient tolerance, and any adverse symptoms. The integration of blood flow restriction training into comprehensive TKA rehabilitation programs requires coordination with the overall rehabilitation plan. BFR sessions should be scheduled on non-consecutive days to allow adequate recovery, and they may be combined with conventional exercises within the same session, with BFR exercises typically performed first when the patient is least fatigued. As patients progress to tolerating higher loads through conventional resistance training in the subacute and late phases, the relative contribution of BFR training may be gradually reduced, though it can continue to serve as a supplementary modality throughout the rehabilitation course. The transition from BFR predominant training to conventional high-load training should be guided by patient tolerance, strength progression, joint symptoms, and clinical judgment rather than rigid time-based protocols, with the ultimate goal of achieving exercise independence at conventional training loads of 60% to 80% of one repetition maximum. Module 6 examines the specific contributions of nursing, occupational therapy, and interprofessional collaboration. Let's start with why ERAS-based nursing protocols matter so much. Nursing care is central to ERAS implementation, spanning preoperative, intraoperative, and postoperative phases, with direct impact on outcomes, satisfaction, and resource utilization. A 2025 study of perioperative nursing based on ERAS principles demonstrated significant reductions in complication rates. 4.4% versus 11.7%, shorter hospital stays at 5.6 versus 8.3 days, and higher patient satisfaction at 94.3% versus 78.6% compared to conventional nursing care. The Power 2 study confirmed that early mobilization, a nursing initiated component of ERAS, was independently associated with reduced complications, with 40% lower odds, providing level 1 evidence for nursing driven early mobility protocols starting on post-operative day 0. Preoperative nursing responsibilities within ERAS are extensive and directly influence patient readiness for surgery and self management after discharge. These include comprehensive patient education using written and technology-enhanced materials, minimizing preoperative fasting to 2 hours for clear liquids and 6 hours for solids per current evidence-based guidelines, preoperative carbohydrate loading, anxiety assessment and management, medication reconciliation, and coordinating preoperative optimization interventions. Intraoperatively, nursing contributions focus on maintaining normothermia through active warming measures, fluid optimization to avoid both hypovolemia and fluid overload, blood loss monitoring and management, including tranexamic acid administration, and surgical safety checklist adherence per the ERAS-specific checklist developed through modified Delphi consensus. Post-operative ERAS nursing encompasses multiple coordinated interventions that collectively facilitate rapid recovery. Early mobilization on the day of surgery, ideally within 4 to 6 hours of surgery completion, requires nursing assessment of hemodynamic stability, pain control adequacy, and spinal anesthesia resolution before initiating supervised ambulation. Multimodal analgesia administration follows a scheduled rather than as-needed approach, with nursing responsibility for assessing pain using validated scales, administering medications at prescribed intervals, and monitoring for adverse effects including sedation, respiratory depression, nausea, and constipation. Additional evidence-based interventions include cryotherapy application and teaching for ongoing home use, knee positioning at 30 to 90 degrees of flexion during the first 7 days to optimize range of motion recovery, deep vein thrombosis prophylaxis including both pharmacological agents and mechanical compression devices, avoidance of unnecessary urinary catheterization to reduce infection risk, and early nutritional resumption. The impact is measurable. Evaluation of early rehabilitation intervention-based nursing care showed significantly better hospital for special surgery knee scores. 30-second chair stand performance, active range of motion, quality of life scores, and lower anxiety, depression, and kinesiophobia at 1 month. And here's something every member of the team should know. Nursing has the greatest impact on overall hospital satisfaction for TKA patients. Communication with nurses is the single strongest predictor of patient satisfaction ratings across multiple domains: responsiveness, pain management, discharge information quality, and overall hospital rating. Now let's address a topic that requires some nuance: home health services and the important distinction between selective and routine utilization. The evidence has challenged traditional assumptions. A large retrospective analysis found that routine home healthcare in Medicare-age patients was paradoxically associated with increased early emergency department visits, 3.3% versus 2.8%, higher readmission rates at 0.9% versus 0.7%, and an additional cost of $1,727 per episode compared to self-care discharge. Complication rates showed no significant difference, 11.4% versus 10.9%. The message is clear: a selective approach to home health referral targeted to patients with identified risk factors is the evidence-based practice. But when home health services are truly indicated, 2 things matter most: timing and dosing. Delayed initiation is associated with lower probability of self-care improvement, lower mobility improvement, and higher 90-day readmission risk. And the dose-response relationship is striking. 6 to 9 visits yield approximately 25% greater improvement in daily living activities. 10 to 13 visits yield approximately 40% improvement, and 14 or more visits yield approximately 50% improvement compared to 5 or fewer visits. And this isn't just about quality metrics. Poor ADL recovery during home health episodes is associated with a 77% increased risk of subsequent hospitalization. That hazard ratio of 1.77 means these patients are nearly twice as likely to be rehospitalized. Adequate rehabilitation intensity is a patient safety concern, not merely a quality benchmark. One more important consideration: mobility status and home environment factors should be assessed jointly when making discharge disposition decisions, as their interaction influences readmission risk more strongly than either factor alone. Let's talk about occupational therapy, because OT provides distinct and essential contributions to TKA rehabilitation that complement what physical therapy does. While physical therapy focuses primarily on mobility, gait, strength, range of motion, balance, and stair climbing, occupational therapy addresses the equally critical domains of self care, activities of daily living, home environment adaptation, adaptive equipment provision, and return to work planning. The American Occupational Therapy Association practice guidelines establish evidence for OT interventions, including ADL training for lower body dressing, bathing and toileting, home environment assessment and modification, adaptive equipment provision, and vocational rehabilitation. These interventions directly impact patient independence, satisfaction, and quality of life, but they're often underemphasized in TKA rehabilitation that focuses predominantly on impairment level measures. Home environment challenges are a bigger deal than many clinicians realize, and occupational therapists are uniquely positioned to address them. Research shows that pre-surgery concerns center on lack of support along stairs and in bathrooms, problematic flooring surfaces, and household clutter creating fall hazards. Post-surgery, the concerns shift to room size and layout, furniture ergonomics including chair and bed height, and stair navigation with and without assistive devices. The important finding: pre-surgery and post-surgery environmental concerns often differ, highlighting the value of both preoperative and postoperative home assessment. Preoperative occupational therapy home visits have been found feasible and acceptable to patients in a preparatory randomized controlled trial. OT also handles adaptive equipment recommendation, raised toilet seats, shower benches, long-handled reachers, sock aids, and dressing sticks that facilitate safe independence with lower body self-care during recovery. The return to work domain is where OT really shines. The OPAL intervention mapping study established a structured occupational advice intervention with 75% adherence to patient objectives and 74% staff adherence, demonstrating the feasibility of structured OT-led work integration programs. The BAWS Work Integrated Care Pathway, incorporating OT-guided return to work planning, showed remarkable results. Median time to first return to work of 27 days versus 43 to 52 days in control groups. 90% return to work at 3 months versus 63 and to 77% in controls, and significantly higher full return to work at 12 months, with odds ratios of 5.0 to 9.3, meaning patients in the structured pathway were 5 to 9 times more likely to achieve full return to work. A 2022 JAMA Network open randomized clinical trial using the Canadian Occupational Performance Measure for individualized goal setting showed a 1.3-point greater improvement in self-rated performance at 3 months compared to usual care, illustrating the value of client-centered outcome measurement in guiding OT intervention planning. These findings collectively demonstrate that structured occupational therapy intervention produces clinically and economically significant outcomes that absolutely justify the investment of rehabilitation resources. Let me round out this module with assessment tools and interprofessional collaboration. The selection of appropriate outcome measures is essential for effective multidisciplinary TKA rehabilitation, and current evidence supports combining performance-based and patient-reported instruments for comprehensive functional assessment. The Functional Independence Measure, consisting of 18 items scored on a 7-point scale across motor and cognitive domains, remains the most widely used outcome measure in inpatient rehabilitation settings, with occupational therapy assessed domains including bathing, lower extremity dressing, toileting, and functional transfers. The AM-PAC 6 clicks short form assesses basic mobility, daily activity, and applied cognition in 18 questions, with a minimum clinically important difference of 4 points and validated use for both outcome measurement and discharge disposition prediction. The Canadian Occupational Performance Measure provides an individualized, client-centered assessment on 1 to 10 scales for both performance and satisfaction, improving clinical decision-making and client engagement in the rehabilitation process. The APTA guideline recommends several performance-based outcome measures with strong evidence for use in TKA rehabilitation, including the KOOS-JR for knee-specific patient-reported outcomes, the timed up-and-go 30-second sit-to-stand, and 6-minute walk test. Here's an important nuance. Self-reported instruments are moderate but inconsistent surrogates for performance-based measures. The correlation varies by instrument, time since surgery, and functional domain assessed. This inconsistency supports the evidence-based recommendation to use both categories of assessment for comprehensive functional characterization, rather than relying on either alone. The health action process approach theory has also been applied to TKA rehabilitation, with a recent study demonstrating that theory-based nursing interventions incorporating action planning, coping planning, and self-efficacy enhancement improved functional outcomes and self-management behaviors. Effective interdisciplinary collaboration is essential for optimal TKA outcomes, particularly in the context of ERAS protocols that require coordinated action across multiple disciplines. An interdisciplinary case management model achieved 79% goal attainment for TKA, with coordinated OT and PT addressing bed mobility, chair transfers, toilet transfers, activities of daily living, ambulation, stairs, and range of motion within a unified treatment framework. This demonstrated that structured interdisciplinary coordination produces measurably better goal attainment than parallel but uncoordinated discipline-specific interventions. Retrospective analysis found that combined OT and PT with home health actually increased the likelihood of discontinuing opioids compared to PT alone, a hazard ratio of 1.10 for knee arthroplasty, meaning patients receiving combined therapy were 10% more likely to stop opioids. That suggests the holistic functional approach, characteristic of combined occupational therapy and physical therapy intervention, may facilitate broader recovery beyond the musculoskeletal domain. Nurse-led telephone follow-up after discharge has proven effective in reducing unnecessary emergency department utilization. One study found 87% of consultation calls were resolved without an emergency department visit, representing cost savings and reduced burden on patients and the healthcare system. Considerations for mobility status and home environment are important in readmission risk assessment, as home environment factors interact with functional status to influence postoperative outcomes and the risk of falls, readmissions, and emergency department visits. Integration of ERAS principles with quantitative rehabilitation training has demonstrated synergistic benefits, including higher hospital for special surgery scores at 12 months, earlier first ambulation, longer 6-minute walk distances, higher patient satisfaction, and shorter length of stay compared to standard approaches, confirming the value of structured, multidisciplinary perioperative care. Communication strategies for effective interdisciplinary collaboration include regular team meetings, shared documentation systems, and mutual respect for discipline-specific expertise, with evidence suggesting that interdisciplinary teams with shared aims and common goals produce superior outcomes compared to multidisciplinary teams where disciplines work in parallel with separate objectives. Module 7. Return to activity, work, and sport. This is what our patients are asking about from the moment they decide on surgery. Return to sport is a primary goal for many TKA patients, and the evidence base has expanded considerably, moving from retrospective surveys to prospective cohort studies that give us much more reliable numbers. A 2026 prospective cohort study of 1,782 patients, published in the American Journal of Sports Medicine, reported that 53.4% of patients returned to at least one sport within 1 year of primary TKA, with a median time to return of 12 weeks. This represents one of the largest prospective cohorts examining this question and provides clinicians with robust data for preoperative patient counseling. A systematic review with meta-analysis confirmed high rates of return to low-impact physical activity after both total and unicompartmental knee arthroplasty, supporting the expectation that appropriately motivated patients can resume meaningful physical activity. A meta-analysis of 28 studies found a pooled mean time to return to sport of 4.6 months, with 91.4% of patients who were active before surgery reporting return to at least one sport. But here's the nuance. Return to sport after TKA typically involves a transition to lower impact activities. Patients commonly move from running and tennis to swimming, cycling, golf, and walking. Multiple factors influence the level of return: preoperative activity level, age, implant type, BMI, and psychological readiness. Unrealistic expectations regarding return to high impact sports should be addressed during preoperative counseling, because the primary goal of TKA remains pain relief and restoration of function for daily living. The European Knee Associates, the EKA, provide a widely adopted consensus framework. They recommend 21 sports activities as appropriate to resume by 6 months, including walking, swimming, cycling, golf, low impact dancing, bowling, and recreational doubles tennis. High impact activities like running, basketball, and singles tennis are generally advised against due to concerns about accelerated wear and implant loosening, though individual factors including implant type, fixation quality, bone quality, alignment, and functional capacity should inform these conversations. The EKA framework provides a useful starting point for clinician patient discussions about activity expectations and helps set realistic goals during the rehabilitation process. Rehabilitation professionals should incorporate the EKA recommendations into discharge planning and late phase rehabilitation goal setting. For working age TKA patients, return to work is often the outcome they care about most, and it has significant implications for economic productivity and quality of life. A systematic review of patients under 65 found that 70% to 90% return to work after primary TKA, with a median time of 62 to 84 days. But there's significant variation based on occupational demands. Sedentary workers return substantially faster than those in physically demanding jobs, and heavy manual labor may require extended recovery or permanent job modification. The work osteoarthritis or joint replacement questionnaire has been validated in a 12-month multicenter prospective cohort study for predicting return to work, giving clinicians a useful preoperative counseling tool. Structured return to work programs make a real difference. The BAS Work Integrated Care Pathway, with structured occupational advice, workplace integration planning, and coordinated employer communication, showed a median time to first return of 27 days versus 43 to 52 days in controls. 90% return to work at 3 months versus 63% to 77% in controls, and rates of sustained full return to work at 12 months were dramatically higher, with odds ratios of 5.0 to 9.3. A systematic review of patient experiences identified key success factors: employer support, workplace modifications, graduated return to work schedules, and clear communication between healthcare providers and employers about functional capacity and restrictions. An important long-term finding: while physical impairments improve most rapidly in the first 6 months, work participation continues improving throughout the second year, underscoring the need for sustained rehabilitation and occupational support beyond our typical 3 to 6 month discharge from formal services. Patients undergoing revision TKA can expect to return to physical activity, but at generally lower levels than after primary TKA. This is an important counseling point because revision patients often come in with high expectations based on their primary TKA experience. A 2025 comparative study found that revision TKA patients returned to physical activity at lower intensity levels, with Tegner activity scores reflecting predominantly sedentary to low activity. Patient satisfaction with these activity levels remains reasonable for many, but expectations need calibration. A systematic review and meta-analysis using grade methodology, a widely accepted system for rating evidence quality, found that physical activity levels after revision TKA are lower than before the revision and lower than after primary TKA. Return to work rates are also reduced compared to primary arthroplasty. Factors influencing activity after revision include the indication for revision, the extent of bone loss and soft tissue compromise, the type of revision implant, and the patient's pre-revision activity level. The bottom line: realistic preoperative counseling for revision candidates is essential, along with modified rehabilitation expectations featuring slower progression timelines and more conservative functional goals. Let's close this module with a criteria-based approach to readiness assessment that should guide all of our return to activity decisions. Contemporary rehabilitation practice has moved away from purely time-based milestones toward criteria-based readiness assessment using validated outcome measures. This makes sense. Individual patients recover at different rates based on surgical factors, preoperative conditioning, comorbidities, adherence, and biological variability. Rigid, time based protocols may either prematurely advance patients who are not ready or unnecessarily delay progression in patients who have achieved functional criteria. The APTA guideline recommends several performance based outcome measures with strong psychometric properties for tracking TKA rehabilitation progress. The timed up and go test assesses functional mobility and fall risk, where clinically meaningful improvement means a change exceeding 2.49 seconds. The 30-second sit to stand test evaluates lower extremity strength and endurance. And the 6-minute walk test provides a measure of functional exercise capacity and aerobic conditioning. Patient-reported outcome measures capture what performance tests can't: the patient's own perspective on function, pain, and satisfaction. The COOS-JR is the APTA's preferred knee-specific measure, with high internal consistency, excellent correlation with the full COOS, and strong responsiveness to change after TKA. The WOMAC provides comprehensive pain, stiffness, and function assessment. Remember, self-reported and performance-based measures are inconsistent surrogates for each other, which is why you need both for complete functional characterization. A multidisciplinary Delphi consensus established personalized activity timelines: driving at 4 to 6 weeks, sexual activity at 6 to 8 weeks, gardening at 8 to 12 weeks, and cycling at 12 weeks, while emphasizing that individual variation based on surgical factors, rehabilitation progress, and comorbidities should always guide clinical decision-making rather than rigid time-based restrictions. The integration of performance-based and patient-reported outcome data enables clinicians to make evidence-informed decisions about activity progression, rehabilitation discharge, and return to activity clearance that are individualized to each patient's recovery trajectory. We've reached Module 8, Case Studies. The following 3 cases integrate principles from Modules 1 through 7 to illustrate how evidence-based perioperative optimization, surgical awareness, rehabilitation setting selection, exercise prescription, blood flow restriction training, multidisciplinary collaboration, and return to activity planning converge in the management of TKA patients across diverse clinical scenarios. Case Study 1. Uncomplicated primary TKA with rapid recovery. This case illustrates the application of a comprehensive ERAS pathway, risk-stratified rehabilitation setting selection, and criteria-based progression in a patient with favorable prognostic factors who achieves rapid recovery through a home-based rehabilitation model. Margaret is 64, a retired school teacher presenting for right primary TKA for end-stage medial compartment osteoarthritis. Her BMI is 27.3. She's a lifelong non-smoker with no opioid history. Her medical history includes well-controlled hypertension on lisinopril 10 mg daily and mild hyperlipidemia on atorvastatin 20 mg daily. Her labs are textbook ready: hemoglobin A1C of 5.4%, fasting glucose of 98 mg per deciliter, hemoglobin of 13.8 grams per deciliter, albumin of 4.1 grams per deciliter, and vitamin D of 38 nanograms per milliliter. No history of blood clots or peripheral vascular disease. She lives with her husband in a single-story home with a walk-in shower. She was walking 2 miles daily and playing golf twice weekly until progressive knee pain curtailed her activities over the past year. Psychologically, she's in great shape: PHQ-9 of 2 out of 27 and pain catastrophizing scale of 8 out of 52, both well below clinical thresholds. She's highly motivated and wants to get back to golf and daily walking within 4 months. Preoperative functional assessment: knee flexion of 110 degrees, extension lacking 5 degrees, tug of 11.2 seconds, 30-second sit-to-stand of 9 repetitions, 6-minute walk test of 340 meters, COOS-JR of 42 out of 100, and WOMAC pain of 14 out of 20. Her RAP score is 10 out of 12, strong predictor of successful home discharge. Margaret's preoperative profile is favorable across multiple domains. Her metabolic parameters all meet or exceed recommended thresholds: fasting glucose well below 126 mg per deciliter, hemoglobin A1C well below 6.5%, hemoglobin above 13 grams per deciliter, albumin above 3.5 grams per deciliter, and vitamin D above 30 nanograms per milliliter. Her BMI of 207.3 places her in the overweight but not obese category, with no increased surgical site infection risk per AAOS guidelines. Her non-smoker and non-opioid user status eliminate two significant modifiable risk factors. Psychological screening reveals low pain, catastrophizing, and no depression, consistent with evidence that resilience predicts better postoperative function. The surgical team performs a right primary TKA with a cemented posterior stabilized implant, standard medial parapatellar approach, mechanical alignment. The anesthetic plan follows prospect recommendations: spinal anesthesia, single shot adductor canal block, periarticular local infiltration analgesia with ropivacaine, ketorolac, and epinephrine, and intravenous dexamethasone 8 mg. Multimodal systemic analgesia includes scheduled acetaminophen 1,000 mg every 6 hours, celecoxib 200 mg twice daily, and gabapentin 300 mg at bedtime, with oxycodone 5 mg available as rescue only. Tranexamic acid 1 gram is given intravenously before incision and repeated at closure. Nursing initiates the ARES postoperative protocol, including deep vein thrombosis prophylaxis with enoxaparin 40 mg subcutaneously daily, cryotherapy application, knee positioning in 60 degrees of flexion, and early mobilization planning. Margaret's interdisciplinary management demonstrates efficient, evidence-based care for a favorable profile patient. Nursing assesses hemodynamic stability on postoperative day 0, confirms spinal anesthesia resolution, and initiates supervised ambulation at 5 hours post-surgery. Margaret walks 50 feet with a front-wheeled walker with standby assistance. Nursing administers scheduled multimodal analgesia and educates Margaret on cryotherapy application technique and frequency. Pain scores range from 3 to 5 out of 10 throughout the first 24 hours, and no rescue opioids are required during the first post-operative day. By post-operative day 1, nursing documents a cumulated ambulation score of 12, above the threshold of 11 that predicts successful home discharge. Margaret meets discharge criteria on post-operative day 1: adequate pain control with oral medications, independent transfers with walker, ambulation of 150 feet, ability to navigate 3 stairs with rail, voiding without catheterization, and understanding of medication schedule and wound care. Physical therapy is initiated on postoperative day 0, 6 hours after surgery. The initial session focuses on ankle pumps, quadricep sets with biofeedback, supine straight leg raises, seated knee flexion to tolerance achieving 72 degrees, and transfer training. On post-operative day 1, physical therapy advances to standing knee flexion, terminal knee extension, and progressive ambulation achieving 200 feet with a front-wheeled walker. A comprehensive home exercise program is established, including ankle pumps 20 repetitions hourly, quadricep sets 10 repetitions 5 times daily, seated knee flexion 15 repetitions 3 times daily, supine straight leg raises 3 sets of 10 twice daily, and standing hip abduction 3 sets of 10 twice daily. Her RAP score of 10 and AMPAC 6 clicks basic mobility score of 20 both predict successful home discharge. Based on the CAPA trial evidence, Margaret is enrolled in a self-directed home exercise pathway with a scheduled 2-week follow-up assessment. At the 2-week telerehabilitation visit, she demonstrates knee flexion of 95 degrees, extension lacking 3 degrees, ambulation of 500 feet with a single-point cane, tug of 14.8 seconds, and satisfactory pain control with acetaminophen and celecoxib only, having discontinued opioids on postoperative day 4. She meets the CAPA criteria for self-directed rehabilitation and continues her home program with telerehabilitation monitoring every 2 weeks. At week 6, knee flexion reaches 115 degrees and extension is 0 degrees. Progressive resistance training is introduced, advancing to 70% to 80% of estimated 1 repetition maximum for 3 sets of 10 to 12 repetitions, 3 times per week. Occupational therapy performs a bedside evaluation on post-operative day 1 and confirms independence with lower body dressing using adaptive equipment, seated sponge bathing with a shower bench, and toilet transfers using a raised toilet seat. OT provides adaptive equipment recommendations and confirms her single-story home is appropriate for safe discharge. No home health OT referral is indicated. Margaret's outcomes tell the story of what optimized, stratified care can achieve. At 6 weeks, she's ambulating independently without any assistive device, driving since week 4, and performing all ADLs without adaptive equipment. At 3 months, 125 degrees of flexion, full extension at 0 degrees, tug of 8.4 seconds, a clinically meaningful improvement exceeding the 2.49-second threshold. 30-second sit-to-stand of 13 6-minute walk test of 420 meters, and Coast JR of 78 out of 100. She returned to daily walking at 1.5 miles and resumed recreational golf at 14 weeks, consistent with the EKA recommendation of golf resumption by 6 months. At 6-month follow-up, high satisfaction, KOSJR of 84, and all pre-illness recreational activities resumed. Total formal healthcare utilization consisted of 2 inpatient therapy sessions, 4 telerehabilitation visits, and no home health or outpatient physical therapy visits. This case illustrates the optimal application of ERAS protocols in a patient with favorable preoperative optimization across metabolic, nutritional, psychological, and functional domains. The absence of modifiable risk factors predicted an uncomplicated recovery. The surgical approach using mechanical alignment with a cemented implant represents the evidence-based reference standard. Risk stratification tools accurately predicted successful home discharge, and CAPA criteria appropriately identified Margaret as a candidate for self-directed rehabilitation. Although blood flow restriction training was not indicated given her adequate pain control and exercise tolerance, it would have been a consideration had she demonstrated significant quadriceps inhibition. This case demonstrates that evidence-based stratification enables appropriate allocation of rehabilitation resources, with favorable profile patients achieving excellent outcomes through predominantly self-directed care. Case study 2 is a very different story. Complex primary TKA with multiple comorbidities and psychological risk factors. Robert is 72, a warehouse supervisor presenting for left primary TKA for tricompartmental osteoarthritis. His BMI is 38.2. He has type 2 diabetes with a hemoglobin A1C of 7.8%. He has a 30-pack-year smoking history and is currently smoking half a pack daily. His medical history includes hypertension, obstructive sleep apnea on CPAP, chronic low back pain managed with oxycodone 10 milligrams 3 times daily for the past 2 years, and a deep vein thrombosis of the right lower extremity 5 years ago. His labs tell a concerning story. Hemoglobin of 11.8 grams per deciliter, albumin of 3.2 grams per deciliter, vitamin D of 18 nanograms per milliliter, and fasting glucose of 162 milligrams per deciliter. He lives alone in a 2-story home with a bedroom and only bathroom upstairs. He's been on modified work duty for 8 months and is anxious about losing his job. Psychological screening. PHQ 9 of 12 out of 27, indicating moderate depression. Pain catastrophizing scale of 34 out of 52. High catastrophizing and brief resilience scale of 2.2 out of 5, indicating low resilience. Functionally, 95 degrees of flexion, extension lacking 10 degrees, tug of 18.6 seconds, sit-to-stand of 5 6-minute walk test of 215 meters, KOSS JR of 31 out of 100, WOMAC pain of 17 out of 20. He also reports bilateral knee pain, chronic low back pain at 6 out of 10, and contralateral hip pain. RAPT score, 5 out of 12. High risk for needing inpatient rehabilitation. Look at what we're dealing with. Hemoglobin A1C above 6.5%, fasting glucose above 1206, hemoglobin below 13, albumin below 3.5, vitamin D deficient, active smoker, chronic opioid use at 30 morphine milligram equivalents daily, high pain catastrophizing, moderate depression, low resilience, musculoskeletal comorbidity burden, prior DVT, and living alone in a 2-story home. Surgery is deferred for 4 months of comprehensive optimization. Watch how systematic preoperative optimization transforms Robert's risk profile. He's transitioned to metformin plus a GLP-1 receptor agonist, achieving hemoglobin A1C of 6.3% and 14 pounds of weight loss by 3 months. Intravenous ferric carboxymaltose corrects his hemoglobin to 13.4 grams per deciliter. High-dose vitamin D loading brings his level to 34 nanograms per milliliter. Smoking cessation with varenicline achieves tobacco abstinence 6 weeks before surgery. An 8-week opioid taper transitions him to duloxetine and topical diclofenac, with complete opioid cessation 4 weeks before surgery. For prehabilitation, BFR training is initiated 6 weeks before surgery at 60% limb occlusion pressure, reduced from standard because his resolved DVT history classifies him as moderate risk. 3 times weekly, using the 30-15-15-15 protocol, his quadriceps strength improves by 22%. 6 sessions of cognitive-based psychotherapy reduce his pain catastrophizing scale from 34 to 18 and PHQ-9 from 12 to 7. Staphylococcus aureus decolonization is completed. The surgical team performs a robotic-assisted TKA, appropriate because Robert is a male patient with poor baseline function, fitting the subgroup that derives greatest benefit from robotic assistance. No opioids are prescribed given his history. Instead, the established duloxetine and a low-dose ketamine infusion for 24 hours. Extended thromboprophylaxis with rivaroxaban for 35 days given his DVT history. Postoperatively, ERAS nursing implements heightened monitoring, blood glucose every 6 hours, close DVT surveillance, twice daily wound assessment. Robert is discharged to inpatient rehabilitation on postoperative day 2 based on his RAPT score and living alone status. PT initiates NMEs for quadriceps inhibition and passive BFR from day 1. BFR progresses through all 4 phases, transitioning to conventional high-load training by week 12. OT addresses ADL retraining, home safety modifications, and develops a BAS-modeled return-to-work plan. At 3 months, 118 degrees of flexion, full extension, tug of 10.2 seconds, COAS JR of 65. Robert returns to full-duty warehouse supervision at 16 weeks, remains completely opioid-free, and has lost 22 pounds total. This case proves that even high-risk patients can achieve excellent outcomes when systematic, evidence-based interdisciplinary care is applied from start to finish. Our final case, Case Study 3, Revision TKA with Postoperative Setback and Telerehabilitation, illustrates the complexities that make our work both challenging and rewarding. Susan is 58, a high school administrator presenting for left revision TKA due to aseptic loosening of the tibial component 9 years after primary TKA. Her BMI is 30.8. Her diabetes is well controlled with hemoglobin A1C of 6.2% on metformin alone, and she has mild generalized anxiety managed with sertraline. No smoking, no opioids, no blood clot history. But here's the wrinkle. She lives 75 miles from the nearest outpatient rehabilitation clinic. Her functional assessment shows knee flexion of 88 degrees, extension lacking 8 degrees, tug of 15.3 seconds, 6-minute walk test of 280 meters, KOOS-JR of 38, and a pain catastrophizing scale of 22, moderate catastrophizing. Her hemoglobin is 12.9 and vitamin D is 28, both just below optimal thresholds. So intravenous iron and vitamin D loading are initiated preoperatively. Staphylococcus aureus screening is positive, and decolonization is completed. The surgical team performs a revision with bone grafting of the tibial defect and a constrained condylar revision prosthesis with cemented fixation and tibial stem extension. The surgeon's critical instruction, partial weight bearing at 50% of body weight for 6 weeks to protect the bone graft. That single restriction fundamentally reshapes the entire rehabilitation plan. And her geographic isolation, 75 miles from outpatient care, makes telerehabilitation not just convenient, it's the only viable option for consistent supervised rehabilitation. Susan's postoperative course includes a complication that tests the team's ability to adapt. Nursing implements modified ERAS protocols. Hemoglobin drops to 9.8 grams per deciliter on postoperative day 1, symptomatic with tachycardia and lightheadedness, requiring 1 unit of packed red blood cells. She's enrolled in a nurse-staffed consultation phone service. Physical therapy initiates NMEs for quadriceps inhibition and achieves 58 degrees of knee flexion by postoperative day 2, notably less than expected after primary TKA, reflecting the more extensive revision dissection. She goes home on postoperative day 3 with home health PT starting 3 days later. Then, at the 2-week home health visit, Susan presents with a setback. Increased anterior knee pain, warmth, new effusion, and most concerning, her flexion has dropped from 68 degrees to 55 degrees, extension has worsened from 5 to 12 degrees, and she can't perform a straight leg raise without NMES assistance. The therapy team immediately contacts the surgeon. Ultrasound rules out DVT. Joint aspiration reveals a sterile, inflammatory effusion, no infection. The diagnosis? Post-revision inflammatory flare, likely related to the bone graft and augmented implant. Therapy protocols are modified, reduced exercise intensity, increased cryotherapy frequency, and gentle manual lymphatic drainage. By week 3, the flare resolves and rehabilitation resumes progression. BFR is introduced at phase 2, but with pressure reduced to 50% of limb occlusion pressure given the recent inflammatory episode. At week 6, the surgeon clears full weight bearing based on radiographic evidence of graft incorporation, a major milestone. Home health PT transitions to telerehabilitation with twice-weekly video visits. BFR progresses through phases 3 and 4, and by week 12, conventional resistance training reaches 50% to 60% of one repetition maximum. Occupational therapy arranges first-floor living during the 6-week partial weight-bearing period, sets up a modified home workstation for remote work, and builds a graduated return-to-work plan. Remote work at week 4, full-day remote by week 6, in-person return beginning week 10, and full-time in-person duties by week 14. Susan's recovery is slower than primary TKA, exactly as we'd expect for revision, and the inflammatory flare during weeks 2 through 4 set things back further. But the outcomes are meaningful. At 3 months, 108 degrees of flexion, 2 degrees of extension, tug of 11.8 seconds, 30-second sit-to-stand of 9 6-minute walk test of 310 meters, and COS JR of 56. Her pain catastrophizing scale decreased from 22 to 12, a real psychological win. She resumed remote work at week 4 and reached full-time in-person duties by week 14. At 6 months, flexion reaches 112 degrees, tug is 10.4 seconds, 6-minute walk test is 345 meters, and COS JR is 62. She's resumed recreational walking and light swimming, but has accepted that her activity level will be lower than after her primary TKA, consistent with what the evidence tells us about revision outcomes. The rehabilitation numbers tell an important resource story. 3 inpatient sessions, 18 home health PT visits, 6 home health OT visits, 22 telerehabilitation visits, and 0 outpatient clinic visits. The estimated cost savings from telerehabilitation versus conventional outpatient rehabilitation, factoring in travel time, fuel, and work time lost for a 150-mile round trip, exceeds $3,000. This case leaves us with several powerful takeaways. There are no evidence-based rehabilitation protocols specifically for revision TKA. We have to adapt primary TKA principles with clinical judgment. Setbacks like the inflammatory flare are a reality of revision surgery, and they require flexible, adaptive management rather than rigid adherence to a timeline. Blood flow restriction was invaluable during the 6-week partial weight-bearing restriction when conventional strengthening options were severely limited. Telerehabilitation didn't just save money, it made consistent supervised rehabilitation possible for a patient who otherwise would have had none, demonstrating the profound equity and access advantages of this modality. Structured return-to-work planning supported both economic needs and psychological well-being, and realistic preoperative counseling about revision TKA activity expectations helped Susan calibrate her goals and maintain motivation throughout a challenging recovery. Thank you for your engagement with this course. The evidence presented across these 7 modules and 3 case studies represents the current state of TKA rehabilitation science, and your ability to apply it will make a meaningful difference in the lives of your patients. We will now review the exam questions to solidify your understanding. Listen carefully as we walk through each question. Identify the correct answer and explain the rationale behind it. Let's get started. Question 1. According to the Power 2 study published in JAMA Surgery, what level of ARIS protocol adherence was independently associated with reduced post-operative complications? The correct answer is B, above 62.5%. Rationale. Enhanced recovery after surgery, or ERS, protocols bundle multiple evidence-based perioperative interventions such as multimodal analgesia, early mobilization, and optimized fluid management. The Power 2 study was a large prospective investigation that quantified the dose-response relationship between protocol adherence and outcomes. Researchers found that when teams followed more than 62.5% of the recommended ERAS elements, patients experienced significantly fewer postoperative complications. This threshold is important because it demonstrates that ERAS is not an all-or-nothing approach. Even partial adherence above this level yields meaningful clinical benefits. Patients in the highest adherence quartile fared the best, reinforcing that the more consistently teams implement ERAS bundles, the better the outcomes for patients undergoing total knee arthroplasty. Question 2. Which of the following patient subgroups has been identified as deriving the greatest benefit from robotic-assisted TKA? The correct answer is C. Male patients younger than 67 with worse preoperative function. Rationale: robotic-assisted total knee arthroplasty offers improved precision in bone cuts and implant alignment, but the clinical benefit is not uniform across all patients. Secondary analysis of randomized controlled trial data identified specific subgroups that gain the most from this technology. Male patients, those younger than 67, and individuals who enter surgery with lower baseline functional scores and reduced quality of life, showed the greatest improvements compared to conventional techniques. The rationale is straightforward. Patients who start with worse function have more room for improvement, and the precision of robotic assistance helps optimize alignment in these cases where surgical accuracy has a larger impact on functional gains. The finding that younger patients benefit more is also clinically logical, as they tend to place higher physical demands on the replaced joint and are more likely to notice differences in alignment and kinematics. Question 3. In the Veritas randomized controlled trial, what were the median 12-week costs for telerehabilitation compared to conventional rehabilitation? The correct answer is A, $1,050 versus $2,805. Rationale: the Veritas trial was designed to evaluate whether telerehabilitation could serve as a cost-effective alternative to traditional in-person rehabilitation following TKA. The results were compelling. Telerehabilitation cost a median of $1,050 over 12 weeks, compared to $2,805 for conventional rehabilitation, representing a substantial cost reduction of over 60%. Critically, this cost savings did not come at the expense of patient outcomes. Functional results were non-inferior, meaning patients who received telerehabilitation achieved equivalent recovery milestones. Additionally, rehospitalization rates were actually lower in the telerehabilitation group. These findings are significant in the context of value-based care, as they demonstrate that remote monitoring and virtual therapy sessions can deliver comparable clinical results while dramatically reducing the financial burden on patients and healthcare systems. Question 4. What is the recommended resistance training intensity for TKA patients during the subacute phase, weeks 2 through 8, of rehabilitation? The correct answer is D, 70% to 80% of one repetition maximum for 3 to 4 sets of 8 to 12 repetitions. Rationale: resistance training following TKA is essential for restoring quadriceps strength, which is the single most important muscle group for functional recovery after knee replacement. Current evidence, adapted from American College of Sports Medicine guidelines, supports a more aggressive approach to strengthening than was traditionally prescribed. During the subacute phase from weeks 2 through 8, patients should train at 70% to 80% of their one repetition maximum, performing 3 to 4 sets of 8 to 12 repetitions, at least 3 times per week for a minimum of 8 weeks. This moderate to high intensity is necessary to produce meaningful strength gains. Lower intensities, while safer in perception, often fail to create sufficient stimulus for muscle hypertrophy and strength recovery. The key is that this intensity range has been shown to be both safe and effective in the post-TKA population when properly supervised and progressed. Question 5. What is the most widely supported repetition scheme for blood flow restriction training in TKA rehabilitation? The correct answer is A, the 30-15-15 protocol, totaling 75 repetitions at 20% to 30% of one repetition maximum. Rationale. Blood flow restriction, or BFR training, is an emerging rehabilitation strategy that allows patients to achieve muscle hypertrophy and strength gains using significantly lower loads than traditional resistance training. This is particularly valuable in the early postoperative period when high joint loads may not be well tolerated. The most widely supported protocol uses a 30-15 repetition scheme, meaning the first set consists of 30 repetitions followed by 3 sets of 15 repetitions with 30-second rest intervals between sets. This totals 75 repetitions per exercise, performed at only 20% to 30% of the patient's 1 repetition maximum. The partial venous occlusion created by the BFR cuff generates a local metabolic environment that triggers muscle protein synthesis and growth hormone release, mimicking the cellular responses typically seen only with much heavier loads. This allows patients to build strength while protecting healing tissues from excessive mechanical stress. Question 6. Which structured occupational therapy-led intervention demonstrated that patients were 5 to 9 times more likely to achieve full return to work at 12 months? The correct answer is B, the BAS Work Integrated Care Pathway. Rationale. Return to work is a critical but often overlooked outcome measure following total knee arthroplasty, particularly for working-age patients. The BAS Work Integrated Care Pathway represents a structured occupational therapy-guided approach to return-to-work planning that begins early in the recovery process. This intervention was remarkable in its effectiveness, showing odds ratios of 5.0 to 9.3 for full return to work at 12 months compared to standard care. To put that in practical terms, patients in the BAS pathway were 5 to 9 times more likely to be back at work full-time within a year of surgery. Early results were equally impressive, with 90% of patients returning to work by 3 months compared to only 63% to 77% in control groups. This study underscores the value of proactive, structured occupational therapy involvement in addressing vocational recovery, rather than leaving return-to-work decisions solely to the patient or surgeon. Question 7. According to the European Knee Associates, or EKA, consensus framework, by what time point are activities such as walking, swimming, cycling, and golf recommended as appropriate to resume after TKA? The correct answer is C, 6 months. Rationale. One of the most common questions patients ask before and after total knee arthroplasty is when they can return to their preferred activities. The European Knee Associates developed a consensus framework to provide evidence-based guidance on this topic. Their recommendations identify 21 sports and recreational activities as appropriate to resume by the 6-month mark. These include low-impact activities, such as walking, swimming, stationary and road cycling, golf, low-impact dancing, bowling, and recreational doubles tennis. The 6-month timeline balances adequate tissue healing and implant fixation with the psychological and physical benefits of returning to activity. It is worth noting that this does not mean all activities are appropriate at 6 months. Higher impact activities may require longer recovery periods or may carry risks that warrant discussion between the patient and their surgical team. The framework gives clinicians and patients a shared reference point for setting realistic activity expectations. Question 8. According to AOS guidelines, what are the recommended preoperative glycemic targets for patients undergoing TKA? The correct answer is D, fasting glucose below 126 milligrams per deciliter and hemoglobin A1C below 6.5%. Rationale. The American Academy of Orthopedic Surgeons strongly recommends perioperative glucose control as a modifiable risk factor for surgical complications. Hyperglycemia, whether from diagnosed diabetes or unrecognized insulin resistance, significantly increases the risk of surgical site infection, delayed wound healing, and other adverse postoperative outcomes. The recommended targets of fasting glucose below 126 milligrams per deciliter and hemoglobin A1C below 6.5% represent well-established diagnostic thresholds for diabetes. By ensuring patients meet these glycemic targets before surgery, clinicians can reduce complication rates and improve outcomes. This is considered a strong recommendation, meaning the evidence supporting it is robust, and the benefits clearly outweigh the risks of delaying surgery for glycemic optimization. For patients who do not meet these targets, Preoperative medical optimization through endocrinology consultation or primary care management should be pursued before proceeding with elective TKA. Question 9. Which of the following is an absolute contraindication to blood flow restriction training? The correct answer is A. Current deep vein thrombosis or pulmonary embolism. Rationale? While blood flow restriction training offers significant rehabilitation benefits, patient safety requires careful screening for contraindications. An active deep vein thrombosis or pulmonary embolism is an absolute contraindication, meaning BFR must not be performed under any circumstances in patients with these conditions. The reason is clear. BFR involves partial occlusion of venous return using a pressurized cuff. In a patient with an existing blood clot, this occlusion could potentially dislodge the thrombus or worsen the thrombotic event, leading to a life-threatening pulmonary embolism. It is important to distinguish absolute from relative contraindications. A history of fully resolved DVT, controlled hypertension, and varicose veins are all relative contraindications. These conditions require clinical judgment and may warrant additional precautions, but they do not automatically disqualify a patient from BFR training. Clinicians must perform thorough screening before initiating BFR in any post-surgical population. Question 10. In the CAPA trial, what percentage of TKA patients successfully self-directed their rehabilitation without supervised physical therapy? The correct answer is C, over 50%. Rationale. The CAPA non-randomized controlled trial challenged traditional assumptions about the necessity of formal supervised physical therapy following total knee arthroplasty. The study found that more than half of TKA patients could successfully self-direct their rehabilitation and achieve outcomes equivalent to those receiving conventional outpatient physical therapy. This finding has important implications for healthcare delivery and resource allocation. It suggests that a substantial proportion of patients, when given appropriate education, home exercise programs, and clear guidelines, can manage their own recovery effectively. This does not mean that supervised rehabilitation is unnecessary for all patients. Rather, it supports a more individualized, stratified approach to post-operative rehabilitation, where resources are directed toward patients who need them most, such as those with significant comorbidities, poor preoperative function, or limited social support, while lower-risk patients are empowered to take an active role in their own recovery. This model aligns with current trends toward value-based care and patient-centered rehabilitation. That concludes our review of all 10 exam questions. Take time to revisit any areas where you felt uncertain, and remember that understanding the rationale behind each answer is just as important as knowing the correct response. Good luck on your exam.